Thank you very much. It's my pleasure, and it's always a pleasure to have the opportunity to educate. That's one of my favorite things to do and has been for the last 40 years of doing addiction medicine. When people ask me about addiction medicine, I've kind of grown up with this specialty. I began my first addiction medicine recovery unit as director in 1984. Addiction medicine was recognized as a brain disease first in 1983. So the specialty and I have grown up together. The topic today is opiate use disorder, prevention as relates to trauma and science. In some ways, in the last 10 years, we have made more advances in the science of addiction medicine than anyone would have thought possible. In other more simplistic ways, very little has changed. In 1984, when I sat at a round table in training in New Orleans, Louisiana, there was mentioned the four major impediments to the diagnosis and treatment of what was then called just alcohol and drug dependence. Those four major impediments were denial, treating addiction as a moral illness, stereotyping the addict and alcoholic, and physician awkwardness with making the diagnosis and referral and treatment. Well, now it's 2021, and those four things still hold true. So in some ways, we've made very little progress. In other areas, we've made tremendous progress. I want to first talk about stigma, which is one of the main things we have to deal with when we talk about the disease of substance use disorder and opiate use disorder. In a Johns Hopkins University study in 2014, 78% of people interviewed still saw drug addiction as a personal failing. That's really sad. With as much education as there's been nationally on the news and otherwise, our population in general still has a hard time accepting that we're dealing with a brain disease. Hopefully by the end of this talk, you'll have a better feeling for that. And it's not only addiction. 40% of people interviewed saw mental illness, including depression, as a personal failing. What's interesting is, excuse me, is that, and I'm going to skip to the fourth thing down here, at any one time in any med-surg hospital, this was true 30 years ago, and it's true now, 25 to 50% of people in inpatient will have a substance use disorder diagnosis, whether it's mentioned on the chart or not. There's certainly a lot of overlap between substance use diagnosis and other diagnoses in medicine. The major factors I want to address today, and one of the most prominent is stress and stress-related disorders. When they came out with a new diagnostic and statistical manual called the DSM-5, they made one major change, particularly with one diagnosis, and that was post-traumatic stress disorder. Anyone who stayed abreast of the treatment of addiction and the opiate crisis know that trauma and the opiate crisis are very intimately related. Up until the DSM-5, PTSD was considered an anxiety disorder. The difference in anxiety and stress is that anxiety has no particular cause. It's a feeling. Stress, on the other hand, always has one or more causes. What's most important about this is that we also know that chronic pain and that opiate use disorder are also stress-related disorders. So we find commonality in post-traumatic stress disorder, the most significant of trauma-related diagnoses, in opiate use disorder, and in chronic pain. We also have a need for increased spirituality and basic human truths. The more complicated, the more integrated, the more scientific we become, the more we need to back up and concentrate on basic human truths and on spirituality. I participate in 5 different national planning conferences across the country. That means that I review at least 180 to 200 proposals of speakers, psychiatrists, social workers, physicians, other individuals who want to speak at these national conferences. And in reviewing these, we see that so many of them are complicated. And we don't need to forget basic human truths as they relate to solutions to both addiction and to mental illness. We don't need to forget that addiction is a family disease, whether it be related to opiate use disorder, and the impact of this family disease on all family members, and the impact on first responders when they encounter opiate use disorder, overdose deaths, and the impact on children. The other is an education on functional MRIs. That's one thing I want people to really become educated about today, because most of the improvements we have, or the findings, new findings we have in research, are as a result of functional MRIs, and I'll explain that to you momentarily. We talked about stigma, an awareness of shame and its relation to addiction and trauma. Here at SMA Healthcare, constantly in treatment team, I'm bringing up that term, shame-based behavior and shame. You can't talk about trauma without talking about shame, and we'll discuss that. We want to talk about education, medicine, and medical treatment for opiate use disorder, which is basically talking about Vivitrol, which is naltrexone XR, methadone, buprenorphine, whether it's in the form of the mono product, Subutex, or in the form of buprenorphine naloxone, the brand name of which is Suboxone. Those are the 3 major things we use for medication treatment. 2 of those have longer acting monthly treatments, that being Vivitrol and now Sublocade. We also want to talk about education and creating cultural diversity and make sure we are able to individualize our approach to different cultures to ensure their engagement in treatment. And we want to educate primary care physicians, because they're on the front lines. And if they're not able to screen better and identify trauma and identify addiction in its early stages, then we're not going to be doing a good job of making any difference in our interventions where opiate use disorder is. Dave Chappelle, who just won the Mark Twain Award as an outstanding comedian, and for his efforts in his lifetime and career in making a difference in the United States, called what we're living in, the world, the age of spin. And I think that's an apt term. And what he meant by that is that people growing up in today's world are confronted by so many things so quickly, and they see so much of it, that we tend to normalize things that are often horrific, things that are tragic, because we see so much of it so quickly. We don't have time to mourn one thing before something else is in our face. And it can become contagious for our children, for adolescents, including everything from suicide to school shootings to other disasters. Finally, we need a concept of what true community and trust is, and outreach where we understand what warm handoffs are in terms of integrated approaches to the treatment of addiction. This is the brain. This is a better picture of the brain. I want to use this as an example of some of the structures most important. If you look at the bottom, you'll see the amygdala. This is the center of emotions. To the right of it is the hippocampus. If you look over kind of upper left, you'll see the frontal cortex. If you look above that, you see the cingulate cortex. Now, those four structures are affected exactly the same way in both post-traumatic stress disorder and opiate use disorder. That can't be coincidence. And what you find is that where there's trauma, the amygdala, the center of emotion, becomes hyperactive, overactive. The other three structures, the hippocampus, which is responsible for memory, becomes decreased in size, particularly on the left, and becomes hypofunctional. The medial prefrontal cortex, the area there on the left upper side, becomes hypofunctional, and it's important for executive function, for decision making, and for emotions. But one of its most important functions is it serves a feedback function to dampen anxiety. It kind of can shut down all of the hyperanxiety of the amygdala. So when it's hypofunctioning, when it's not functioning normally, it allows the amygdala to really hyperfunction. And finally, the cingulate gyrus, particularly the anterior portion, is important for decision making. In people with post-traumatic stress disorder, the three areas that are hypofunctioning, the hippocampus, the frontal cortex, and the anterior cingulate gyrus, account for the emotional numbing that patients feel that they don't know the reason for. People with PTSD also have extreme anxiety, hyperanxiety that almost feels chemical. They also have a startle reflex, and they're always on edge. That's accounted for by the hyperanxiety of the amygdala and the low function of the frontal cortex, because it's lost that feedback mechanism to push down the hyperanxiety of the amygdala. In opiate use disorder, we find the exact same thing. Overactivity of the amygdala and low function of the hippocampus, the anterior cingulate gyrus, the frontal cortex. It's not so important to remember these names as it is to know that the findings are identical in these areas of the brain. One thing that should tell you, and 2 years ago, I presented at one of the largest conferences in the country, and my theory was that the brain chooses opiate addiction as the brain's drug of choice or a disorder of choice for PTSD. A large National Review article just came out that proposed the exact same thing I proposed 2 years ago with the same reasoning that I did. So I think it's become increasingly true that in people with severe trauma, the brain chooses opiates as the drug of choice for those individuals. Once they find opiates, they don't want other drugs. They may use other drugs, but opiates are the drug of choice. I said I would talk about functional MRIs. Let me explain the importance of functional MRIs. There's one law that makes them work, and that is this. The brain is made up of nerve cells called neurons. There are billions of nerve cells or neurons within the brain. What makes functional MRIs work is the fact that nerve activity is proportional to blood flow in the brain. So as nerve cells are more active, blood flow is more rapid. Because of that, they can color code blood flow in the brain, and that ends up exemplifying activity in different areas of the brain. By doing that, we've made so many strides in research that we had never made before. I'm going to show you some pictures of a patient with PTSD, a patient who's depressed, and a patient with bipolar disorder that demonstrates this. Not only that, but see these lights that are showing on the brain? That's not a good demonstration, but they can actually inject into the brain microscopically lighted particles into a neuron in a certain portion of the brain. A good example is the cerebellum. The cerebellum in the brain, we always thought, for instance, in alcoholism, was only important in what's called combined cerebellar degeneration. Over years, if a person drank long enough and their alcoholism was severe enough, they would develop ataxia. It would affect their sense of balance. We didn't think that the cerebellum had much to do with anything else related to addiction. Well, now we can inject one of these litons into a nerve cell, put it in the cerebellum, and guess what? It travels to all these different locations within the brain, locations that are involved in craving, locations involved in the reward system, locations involved with emotion. And so by doing this in functional MRIs and what we call optogenetics, we're able to see that areas of the brain that we thought had only one function have multiple functions in addiction. So we're finding out all these new properties. Without getting too complicated, I want to show you these slides I was talking about. Here's a slide on the right of someone with no PTSD, okay? When there's low activity on a functional MRI, you're going to see more blue colors, darker colors. And someone who has normal brain activity, you're going to see what you see on the right, kind of green and a little yellow. When there's some hyperactivity, you're going to see red and more yellow. If you look at the PTSD patient, where we talked about hyperactivity, and remember that's demonstrated by increased blood flow, that is a marker for increased nerve cell activity. See the difference in red activity on the left versus the right? That shows that in PTSD, it explains why people with PTSD are so anxious, so on edge, have a startle response. So this functional MRI is a good demonstration of that. Here's a perfect demonstration of a depressed individual versus a not depressed individual with a functional MRI. See how in the not depressed individual, we see more yellow. There's some blue certainly, but compared to the depressed individual, we see so much less yellow and much more darker blue, so that blood flow is much decreased due to decreased neuron activity, and we're able to actually diagnose depression based on a functional MRI. Here is the one that is so obvious in a bipolar brain. Here's someone who is manic in the midst of a mania. In a manic state, look how bright red the bipolar brain is compared to a normal brain. So does everyone get a feeling somewhat for what I'm talking about? How blood flow is related to nerve cell activity and how these colors are used as brain mapping in different areas to show us what nerve cell activity is and how that's what we're making the main advances in research. Does that make sense? Okay. We talked about stress. The connection is a common denominator of stress. PTSD is recognized as a stress-related illness. Stress is recognized as predisposing to opiate addiction. Then we have the negative reinforcement theory, which is the main accepted theory for how opioid addiction occurs. And then continual stress leads to chronic pain. One of the terms I want to talk about is neuroplasticity. We used to think that the brain changed very little after the age of 1 or 2. At one point, we thought it didn't change at all after a baby was born. Then we thought it changed up to maybe age 2. We now know that the brain is capable of changing throughout an individual's life. We call those changes neuroplasticity. In other words, the brain can form neuroplastic pathways. But in order to do it, the brain has to want to do it. The changes it makes could either be positive or negative in terms of the effect on that person. In terms of a negative effect, a good example would be the opiate use disorder pathway. When a person begins to have use of an opioid, they go through 2 stages. The first stage, well, let me say this, it begins as a memory trace, and then the reward system's involved, and then there's motivation to drug seeking. But here's the first stage of neuroplasticity. It's called the tolerance stage. It's the most common. It's where the person develops physical dependence. When you talk about addiction, what physical dependence means is if you take any mood-altering substance and you take it long enough and you stop it abruptly, you're going to experience withdrawal. That does not mean you're addicted. That just means you have physical dependence. So in the tolerance phase of neuroplasticity, you have physical dependence, and you'll have episodes of relapse, getting sober, episodes of relapse, getting into recovery, and it goes back and forth. Unfortunately, the only other form is compulsive drug seeking. Now the neuroplastic pathway is getting more entrenched. You have dopamine release, and as more and more dopamine is released, as drugs are being used over and over and over again, your endogenous opioids, like endorphins and kephalins, they're continue to be released within the brain until they're exhausted. So whether you're using oxycodone, roxicodone, fentanyl, carfentanil, whatever you're using, all your endogenous opioids get used up. That's the reason people, when they run out of a drug or stop using, the rebound withdrawal is so severe because there are no longer any endogenous pain relievers left in the body. What happens then is that you get compulsive drug-seeking behavior. It becomes a chronic brain illness without choice and the potential for relapse. An opioid neuroplastic pathway has been created, and this patient will meet criteria for severe opiate use disorder. One of the things that's interesting is that when you reach that place of neuroplasticity where you have a severe opiate use disorder, the type of memory the brain has changes. In the tolerance phase, you have regular declarative memory where you can remember what happens just like any normal person. But when you reach that phase where there's no choice, you go to what's called procedural memory, which is intuitive memory. It means like somebody hasn't ridden a bicycle in 20 years and can just get on a bicycle, or somebody goes and opens the refrigerator without thinking about it, but just knows how to do it. It means that you implicitly do a behavior without thinking it. And that's what opiate use disorder is. It's lack of choice, and the memory is ingrained to use. It's a ritual. Epigenetics is the only other thing I want to talk about as a new term. Epigenetics is a study of gene expression that does not involve the DNA sequence. I know that some of the stuff is pretty heavy, but I want to just introduce it to you because you're going to hear more and more about it over the coming years. It's like marks or scars on genes, and it turns on or silences certain genes that dictate cell function. Let me put it as simply as I can, and this looks like a complicated graph, but it's not. You have DNA, pairs of DNA like every individual has, but that DNA has to be protected. So the DNA is wrapped in a spindle that's called a histone spindle. And the spindle is made up of 3 proteins that repeat themselves over and over again until the DNA is completely wrapped up. When the pairs are completely wrapped up within a cell, there's usually a little terminal end that sticks out. On that terminal end, other protein groups will attach themselves. This has been where all the research has been done. We find that methyl groups in particular like to attach to the histone spindle. Remember, it's not changing the DNA, so this is not genetic encoding of the DNA. It's attaching to something outside the DNA, hence the name epigenetic. So we found that hypermethylation, when a bunch of methyl groups attach to the end of that spindle, it's associated with the development of post-traumatic stress disorder. It's associated with the development of opiate use disorder. Acetyl groups attaching can be associated with the development of cocaine use disorder. Different attachments have even been associated with a study of suicide, post-mortem studies in Europe in females who committed suicide. So epigenetics is an up-and-coming field. And if you really understand what I'm saying, we're talking about in the future a whole area of study where someone can experience trauma, it can skip generations, as can addiction. But because this doesn't involve the DNA, it can happen generations down the line, and a person can still be at risk for a particular type of addiction. It also means if we can find a way through research to decrease the hypermethylation at the end of that protein, we could actually cure that person's addiction. Many of us believe that within 10 years' time, there'll be a new kind of pharmacy that's called pharmacogenomics. And the genome is the whole cell, including the nucleus, the histone spindle, the DNA, where a person could go to a pharmacy and actually request a medication for hypermethylation to treat their PTSD or to treat their particular addiction. That's not a fantasy. That's going to happen, believe me, within your lifetime. That's how much progress we're making in the addiction field. One of the difficulties we have in diagnosis and treating people is the symptoms are so alike. I want you to look at all these symptoms: loss, isolation, conflict, stress, negative thinking habits, unrealistic thoughts. Just read down that list. The reality is this could be depression. All those symptoms could also be opiate use disorder. All those symptoms could also be PTSD, and all those symptoms could also be chronic pain. I'm going to skip this. These are major structures involved in stress. I'm going to skip this too. I'm going to skip this too and go on to the effects of chronic stress on what happens in the brain. The brain is changed because of what happens with stress. The brain changes in terms of neuroadaptations in the reward pathway. There's less dopamine. You have less sensitivity to rewards. You have less dopamine receptors. You have anhedonia, less joy of life, and resulting depression. Now I want to tell you about the definition of addiction. Addiction is a primary chronic brain disease or brain reward. Dysfunction in the circuits of the brain lead to characteristic biologic, psychological, social, and spiritual manifestations. It's reflected in an individual pathologically pursuing reward or relief of substance use or other behaviors. And this is the most important part. This is about denial and addictive thinking. It's characterized by the inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems. When you see the addict do things that make no sense, they don't recognize what they're doing. It's part of that lack of choice with one's behaviors and interpersonal relationships and a dysfunctional emotional response. Like other chronic diseases, addiction often involves cycles of relapse and remission, and without treatment going to the bottom, it can result in disability or premature death. Talk about families a moment. This first sentence, I think, says it all. In 2017, there were 8,550,000 children living in the United States with someone other than a biologic parent, 45% of which were on the basis of drug addiction. The rate of female suicides, according to the CDC, 15 years of age and younger, is the highest it's been in the last 40 years. A history of drug abuse is a primary reason for homelessness in America. It's associated with depression. 1/3 of abused children will become abusive parents. 70 to 80% of adult sex addicts are survivors of physical or sexual abuse as a child. According to the U.S. Department of Justice, being abused or neglected as a child increases the likelihood of arrest as a juvenile by about 60%, arrest as an adult by almost 30%, and arrest for violent crime by 30%. This all begins very early, folks. 60% of children move from the home. The most common reason for removal is neglect. Imagine a parent overdosing in a home and a child finding them. That child suffers toxic stress and trauma in the family, where one is likely to see the risk of accidental overdose for small children, births with neonatal abstinence syndrome, children taking on a parental role they're ill-equipped to handle, genetic loading of opioid use disorder, increased absences from school, increased risk of psychological, physical, and sexual abuse, and removal from home. And adolescents, unfortunately, think they're Superman. They're risk takers, and by far the majority of first-time opioid users do it as a result of peer pressure. When we talk about medication treatment, there are positives and negatives for each. For methadone, it's an addictive substance. It's a pure mu agonist, no different than oxycodone or oxycodone. The difference is it's given in a controlled setting where it can be given daily, and it can be controlled in federally approved clinics. The benefits are there's decreased craving, there's harm reduction in a controlled setting. It has a long half-life. There are standards of care that has to be followed. It's useful in pregnancy and addicted mothers. And you don't have to delay in starting patients on it like you do with buprenorphine. Tolerance develops is one of the negatives. It's an abused drug. Some clinics are not well managed with poor dosage maximums, and there's a risk of overdose, cessation, and restarting of your last dosage. I love buprenorphine. I think it's the best drug we've had for addiction. And let me say this, the World Health Organization, the American Society of Addiction Medicine, SAMHSA, every leading society or organization where addiction is concerned will tell you that medication treatment is the #1 treatment for opiate use disorder. The benefits of buprenorphine is it's a mixed partial agonist and antagonist. What that means is, unlike methadone, for instance, it has a little bit of euphoric effect, but it has a very low ceiling. When you get to 24 milligrams, it becomes antagonistic. It's not mood altering except in people who've never taken opioids or people who've been away from opioids for a long time. It decreases or stops craving. It has little, if any, tolerance. It can be a good analgesic for people with chronic pain. It's not a drug of abuse. Typically, when it's bought on the street, it's not for abuse, but it's addicts wanting to treat their own withdrawal. It's become a drug of choice now for opiate-addicted pregnancy, and it's a great drug for opiate detoxification. The negatives are withdrawal can be difficult if the physician is not properly educated on how to do tapering. Diversion has become a major problem in prisons, and diversion on the street is mainly as a means of treating withdrawal. Naltrexone is a very useful agent as an anti-craving agent and harm reduction. It's not mood altering, so it's the only of the three that has any addictive potential. It requires only monthly injections and is not addictive or abusable. It reduces or stops craving. It's favored by the court system, and it's good for alcohol and opioids. I will say that when I first got here a year and a half ago, I went to all 7 county judges and convinced each of them to use buprenorphine as an option in the courts. The negatives are the cost is higher. It has a higher relapse rate early on. And you have a problem with skin reaction at the injection site sometimes. And the other negative is a patient has to wait 7 to 14 days from their last use to start it. And oftentimes that's difficult for the alcoholic or addict. And it's not a drug of choice for opioid pregnancy, so you have to change to another drug. I'm going to skip the part on pregnancy. I'm going to skip this part. I want to talk a minute about shame. The difference in guilt and shame, guilt is public. It's for things you do you feel bad about, and guilt has no place in early recovery. I tell patients that when they feel guilty about something and they hang on to it, that's just their addiction, their opioid addiction whispering in their ear. It benefits nothing but the addiction. And if they feel too guilty long enough, the only reward's going to be using again. Shame is usually rooted in childhood trauma. It's hearing the old voices telling them they're not good enough, they did this wrong, not meeting expectations, etc. And shame becomes how they see themselves as a person. And they inwardly, verbally abuse themselves over and over again whenever they feel this feeling of inadequacy, self-loathing, or inferiority. This next slide is a list of some shaming behaviors: perfectionism, verbal abuse, physical abuse, sexual abuse, abandonment, religious piety, neglect, perceived or stated unobtained expectations, the pedestal, profound loss, bullying, academic failures as a result of untreated learning disabilities, conditional love, use of the child as leverage in separation or divorce, child taking on a parental role early, public humiliation. Terms patients use internally without saying it out loud to describe their shame: I'm defective, I'm unacceptable, hopeless, dirty, used, unworthy, unlovable, ugly, failure, incompetent, flawed, phony, unimportant, disgusting, useless, undeserving of happiness, inferior. Shame, an unhealthy gift, and their relation to addictive thinking and behavior. Shame and addiction they overlap each other. You can't treat addictive thinking and addiction without treating shame when it's there in a patient. You have to treat both together. Needing problems is part of addictive thinking. Isolation is part of addictive thinking. Reactive anger and blaming others is part of addictive thinking. Denial and self-deception is part of both. Shame-based thinking won't ask for help, neither will addiction. Obsessive compulsive nature of shame and addictive thinking. And the list goes on and on. Looking for a quick fix or immediate gratification, distorted reality, rationalization, rigidity, hypersensitivity of emotions. Addiction and shame-based depression, trust issues, going fast, a return to old thinking as a first step to relapse, being spiritually bankrupt, and lack of humility. The dangers of shame is that it leads to addiction, domestic abuse, and sexual violence, and it may lead to living a life of fear. It interferes with the ability to form healthy relationships.
43. You're at 40.
And you're unable to enjoy the successes of your life. This is a shame cycle. It shows that it begins with making a mistake. That's what underlies all shame. You feel deep guilt and regret. You dwell on the mistake. You feel so depressed you can't do anything about it. You decide to cheer yourself up through risky behavior or using, and you're right back at making a mistake. And I want to compare this to the addiction cycle. You start out by using, let's say, fentanyl. You feel guilt and remorse. You feel shame and depression. You get up the next morning and make a commitment to do better. The problem is you have to perform. And the stressors, there's that word again, stress. Look how many of them are shame-based. Fear of failure, relationships, anger, the first defense mechanism is shame. Fear of rejection, expectations, all shame-based. So you're set up to fail again, make mistakes, and end up using again. Basic human truths. I just want to mention a couple of these. I'm at 40 minutes. I think by age 3 to 5, all children learn unconsciously it's either safer to express hurt or anger outwardly. And they do that the rest of their lives, and many of us don't even know we do it. So if you do anger easiest, it means a lot of times when you're angry, that's really hurt or fear unexpressed. If you do hurt easiest, a lot of times you express tears and hurt. That may be anger and or fear unexpressed. The need to be right interferes with so many relationships, and being right never helped the relationship. My second most important coping skill with patients is having no expectations, especially of family. When you have no expectations, you can be just as grateful when something good happens. But when you have unrealistic or unspoken expectations, which is the kind we usually have, it sets you up to be hurt, disappointed, and resentful. Life is a struggle. The sooner we accept that, the easier it becomes. And our struggles can be blessings as we mature in trust and faith. I want to go to the last thing. Humility and spirituality cannot be separated. For humility means knowing what your talents are and your inadequacies are and paying attention to neither. It is realizing that I'm no better than my fellow man and he's not better than I. We're basically the same. This commonality is essential to a healthy view of spirituality in terms of how we treat and care for each other. It's ultimately about love, being out of yourself, and learning the art of being a healer and someone who cares for others. Humility is the opposite of shame. My last slide is a quote by Anais Nin, and it's about shame. It says, "And the day came when the risk to remain tight in a bud was more painful than the risk it took to blossom." Thank you.
Thank you so much, Dr. Fenley. I'm gonna just share my screen so that we can see faces again. We're going to go ahead and open it up for questions. So if you have questions for Dr. Fenley, you can add those to the chat, or you can raise your hand and I will ask you to unmute yourself so that you can ask your question. I know that was a lot to think about and all that really interesting science, but we'd love to hear some questions. Okay, Karen, I'm gonna send you unmute.
Hi, Dr. Fenley. Thank you so much for always being the educator that you are. And I appreciate the fact that you're such a recovery champion. My question is, how I once heard you talk about the antidote for shame is humility. Can you elaborate on that a little bit for us, please? He's muted.
Oh, let me see what happened, Dr. Fenley. I sent you a message, Dr. Fenley, to unmute.
I'm used to doing that when we're in a treatment team. I'm sorry. Can you hear me now?
Yes, sir.
Okay. You know, that was kind of an epiphany for me. I had done so much work in shame, and I was doing a preparation of a talk on spirituality and humility, and it dawned on me that it really is the opposite. Humility, if you think about it, means that I'm no better than anybody else and nobody is better than me. Okay? Well, if I truly believe that, how can I have shame? And the other thing is that humility is directly related to spirituality. So if I believe in something greater than myself, and in my case, it's a God of grace, and I'm not saying that to anybody else, everyone has their own beliefs. And that's a loving God who accepts me fully, loves unconditionally, and forgives everything I've done or will ever do, then shame has no place there. So for me, humility is like, I have a little thing I do where I do a drawing. I mentioned the pedestal, which is a lecture I give sometimes to patients. If you think humility as a line, below it is low self-esteem and above it is increased ego. And increased ego is a lot of those things that we shame people with, you know, like perfectionism, religious piety, those things I mentioned. Low self-esteem you can think of as shame, okay? That's what a lot of it is shame and shame-based behavior. And up here where we have the increased ego, you could say, well, where's God in that? Well, there's no place for God when we've got all this stuff up here, right? So we have to get rid of all that ego stuff. Then we can put God up here. And if everybody's here with humility, that's a pretty good representation of a 12-step recovery program, isn't it? And guess what? There's no place for shame because humility is the opposite of it. Does that make sense?
Yes, very much to me. Thank you so much for explaining that.
Thank you, Karen. Other questions? Dr. Fenley, there's such a strong connection between trauma and opiate use disorder. What is science telling us about early interventions for especially children that have experienced trauma to help them heal before the cycle continues where they seek substance to heal?
Well, I think the difficulty there, Terry, is that so often, I think that, first of all, trauma is grossly underdiagnosed in our country. I think our screening procedures for it are poor. We have different tools we use diagnostically. And I hate to say this, but in psychiatric hospitals, insurance does not pay for the diagnosis of PTSD. Many insurers do not pay for that as a primary diagnosis. They pay for bipolar disorder, they pay for major depression, they pay for schizoaffective disorder, they pay for schizophrenia, but they don't pay for anxiety disorder, they don't pay for PTSD. And that's really a shame. I used to think that the reason after working, and I worked in psychiatric hospitals for 26 years, working alongside 5 or 6 psychiatrists at a time, being the only non-psychiatrist as the head and director of addiction treatment. I would share a call, see their patients on the weekend, and I noticed that I would hardly ever see PTSD as a diagnosis. And I used to think, well, maybe they're just uncomfortable talking about it or whatever. And just kind of recently it dawned on me, it's maybe because they don't get reimbursed by insurance. I don't know which of the two it is, but the reality is it does not get diagnosed enough as a primary diagnosis. I think it's because some people are uncomfortable about talking about it. Patients tend to often not want to mention it. I have a way of dealing with it, which even people at SMA really don't like me doing, but in other areas of the country they do, where I will actually talk to a patient and kind of tell them what they experienced as a child when they're an adult. And they say, how do you know all these things? And I say, because I've been doing this for 25 years. And so they immediately trust me because I know the answers. But it's just grossly underdiagnosed is one of the real troublesome things. The thing about it, as an adult, say who's a sexual abuse survivor, they have a 1 to 2% false positive, false positive response. In other words, they're going to tell you the truth if they were or not. They're not going to lie to you. They're not going to say I was when I'm not. With children, that's different. They can have a higher response of giving you saying, yes, I was when they weren't. So it's a little more difficult with children. Plus, you have to have a real specialist there to talk about it. And it's very difficult with children. And I'm certainly not an expert with children. We have it's so multifactorial when you think of homelessness, neglect, abandonment, physical abuse. And it's not just experiencing abuse, it's witnessing abuse. A child in a home watches domestic violence, and they can have post-traumatic stress disorder just on that basis. There's so many forms of it that we're not addressing. So it's so rampant that it's very, very overwhelming in terms of the job we have to do to try to change this educationally. And it really goes all the way back to the lack of extended family and family structure. And that's the world of spin. I said the world of spin. When things were more isolated, when you were in a rural community, when you had extended family and everybody sat down at the supper table and you dialed the telephone like this and you didn't communicate with somebody 1,000 miles away in 3 seconds and it didn't appear on television what happened 2 minutes ago, the world was a simpler place to live, less complicated, and I think it was a lot healthier. Now things happen so quickly. You don't have time to mourn one trauma or how to identify one trauma and its significance before another happens. And that's what we're dealing with. Internet addiction, sexting, gaming, all of it. And, the damage done just in gaming alone with children who spend hours and hours in front of that is damaging. There's no simple answer.
Thank you very much. Aaron, you have a question?
Yes, how you doing, Dr. Fenley?
I'm doing fine, thank you.
My question is basically, if somebody has been suffering with opiate use disorder for a period of time and the dopamine levels in their brain start to go down, and then if they're taking the buprenorphine, will those levels ever come back up while on buprenorphine? Will they ever be able to experience that joy or happiness while still
Are you talking about the endogenous endorphins?
I can't remember exactly what that was called, but
what come back up? I couldn't hear you. There's such an echo.
I guess yeah, it would be that. Just like the dopamine levels, would they be able to come back up and just being able to experience joy and happiness after a period of time while still taking the buprenorphine?
Here, have her ask him.
There's so much echo where you are. Let me turn down my mic some, see if I can hear you better. Go ahead, say it one more time.
Okay. So basically, I was just wondering if you're on the buprenorphine, will you end up experiencing like that joy and happiness, like say somebody who's not on it and is in recovery would feel? Will they kind of start to feel somewhat normal again?
If they go off of it, will they start to feel normal?
If they stay on it.
Will they start to feel normal again? In other words, will you reach a place where you'll go back to homeostasis like you'd never used drugs?
Somewhat like that, yes.
That's a great question. The question and the answer to that is really interesting. I'm so glad you asked that. You know, I mentioned neuroplasticity. The length of the addiction has something to do with it, but a lot of it has to do with 12-step meetings, therapy, and buprenorphine. We know that buprenorphine can weaken the neuroplastic pathway over time, which none of the other two drugs do, okay? But when you go to AA or NA, and remember I said neuroplastic pathways are about repetition, right? It's about repetition, same thing over and over again, the ritual of addiction. So are 12-step meetings. You go into an AA or NA meeting, they read the same introduction, they read the same closing, you read the same quotes from the AA or NA book, you read the prayer, you say the serenity prayer, you know, what's say here stays here, all of it is repetitious. The more you engage in sober thinking over time, the more you hear, say, talk to your sponsor, you're building another neuroplastic pathway that thinking and behavior is the exact opposite of the addictive neuroplastic pathway. And it's a known fact, when competitive neuroplastic pathways are in place, the one that grows stronger as you're in recovery, the other grows weaker. So yes, the longer you're in recovery, the longer you're on buprenorphine, Aaron, and the more you attend 12-step meetings, the bottom line is you can weaken that to the point that it will almost disappear.
Okay.
And that's scientifically sound information and a great question.
Thanks, Dr.
That's
Fenley.
one more thing we've learned from functional MRIs and neuroplasticity.
Thanks,
Good to
Darren.
see you, by the way.
I think we have time for one more question. Bill, would you like to ask your question?
Sure. Hey, Dr. Fenley, it's Bill Blower here.
Hey, Bill, how you doing, buddy? Love you.
I'm doing great, man. I'm doing great. So quickly, I want to tell everybody, I'm going to put a plug in for Dr. Fenley. He's going to be on August 28th. He's going to be over at the drive-in church in Daytona Beach Shores for the Volusia Recovery Alliance overdose awareness thing. He's going to be our main speaker there. So I hope you all come out and support Dr. Fenley and our organization and the county. But and I'll move on to my question now. So now that I got the commercial in. So Dr. Fenley, there's something that I think most questions I've asked you before, but this is one I've never asked you before. I've been seeing a lot of increase in the use of EMDR early on in treatment, you know, combined with buprenorphine and treatment centers and everything. It seems like I'm seeing some success in reduction of stress and anxiety as a result of that. I know it wasn't that long ago. A lot of times those types of therapies were said that maybe it's better off to put them off a little while or whatever. So I'm interested in what your thoughts are on that, and you know, if there's research, you know, shown, you know, which way we should go with that.
I think it's a case-by-case basis, Bill. I think for some patients, you wait a while if they're not ready for it. I think sometimes the criteria who's ready for it has to do with the individual, how engaged they are in treatment. If there's someone who's totally blocking, not engaged, EMDR is not going to work because they're not going to be someone who's amenable to it. If there's someone who's engaged and wants it and is open to it, and you think it's going to be able to do it, earlier the better. I'll give an example. I have a family member who about 2 years ago we never knew had been a victim of any kind of abuse, and then suddenly had a visual flashback of the abuse and had flooding of memories. And you know what flooding is and that kind of thing. It's the worst feeling in the world. And it went on for a period of days, and he fought through it, went to work and everything. And I was able to call someone in town he lived in. He was able to see a therapist who immediately used EMDR with him. And he was placed on Zoloft. And I'm happy to say that the EMDR worked wonders. Within a week or two of doing EMDR, and I mean on a pretty intensive basis, his flooding stopped and he improved dramatically. So it's strictly a case-by-case basis, but I have kind of a problem that the tone has been to delay MDR, and I think it's a wrong tone. I think it's something that can be used early. I think it can be effective. I think it should be used more early than it typically is.
Thank you. I think we have one more question. Yes, sir. I asked you to unmute. Can you talk?
Yes, I'm Dr.
Great.
Ivan Kaur from Florida Healthcare Pain Management.
Uh-huh.
Thank you, Dr. Fenley, for a great, wonderful the discussion today. I wanted to ask one thing: does buprenorphine, when do you think will be available for chronic pain use?
Well, I'll tell you my feeling on that. I don't just use it for chronic pain, so I'm not in a position to do that. But if I have a patient who's in buprenorphine maintenance, who I feel, has a chronic pain issue, it's certainly going to be something I use it for in that situation. Do I think it's a good choice standalone for chronic pain? It depends. It would depend, quite honestly, if I were in that field, on screening the patient, just what I was talking about, looking at the epigenetic history, looking at the history of addiction in that family, looking at so-and-so, and I would make a conscious decision based on that. Because a lot of times we don't realize, the reality is, and I don't know, a lot of you may not know this, but the United States has the least pain tolerance by 99% of any country in the world. So we have the worst pain tolerance of anyone. We make less than 8% of the world's pain medication, and we use over 85% of the world's pain medication.
Agree.
So I think that on a case-by-case basis, if I were in that field, I certainly would. If it were appropriate, given the patient's circumstances, epigenetically, genetically, history of opiate use disorder, whatever, then I certainly would use it.
Okay. Thank you.
Thank you very much for your question. Thank you, Dr. Fenley, so much for being here today. We really appreciate it. We could probably talk to you for another hour, but we're going to go ahead and wrap it up. And as I said before, the recording of this will be placed on our YouTube channel. And please join the VRA at their event so you can hear more from Dr. Fenley. Thank you all for being here, and have a fabulous rest of your day.
Thank you, Carrie.
Thank you.
Bye-bye.